Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Sara. How are you doing today?
I'm doing wonderful. How about yourself?
I'm doing pretty good. So today, I would like to talk about probably one of the scariest things I can ever imagine, and that is pediatric burns. So since this is the first time you're on the podcast, would you mind doing just a quick introduction of yourself?
Of course. My name's Sara. I'm a pediatric intensivist at USU doing pediatric combat casualty research. And I want to echo that. I do think burns are the scariest thing because we have so few isolated burn centers across the U.S. that even very few intensivists get to interact with them as well.
I've encountered a few of them in my time, and each and every time I felt completely retarded and didn't really actually know what to do, even though for the most part it's the same thing, right? So just jumping into it, receiving a burn patient, all right? So everything is puckered up, is about as tight as it's going to get. Can you just walk me through the assessment of a burn child, like somebody's running them to you?
Yeah, so I think that the first thing to remember is that with any trauma assessment, it's the same as the adult. So you're still going to do either the MARCH algorithm or ABCDE, kind of whatever your algorithm of choice is. So you want to stop the bleeding first. Try not to get distracted by the burns. It's hard to look away from pretty gruesome extremity injuries and large burns, but get back to the focus on the algorithm. So stop the bleeding. Airway. Is my airway patent or not? Breathing, again, is the same. They breathe a little bit faster, but is it comfortable or not when you look at them is one of the biggest tells. Circulation, again, do they have a pulse? You're going to want to feel brachial for the infants. You can do radial in older children, but fem pulse is always going to be the better bet for central pulses. Otherwise, it's then hypothermia and head injury. So really the main principle is the same. There's just some subtle nuances in each of those, which we can talk about individually.
Yeah, absolutely. And especially any burn patient, they're going to respond to that burn. There's going to be a lot of pain. Everybody around them is going to be upset, and their stress level can start affecting you. But if you can just focus on, focus on March, like most, especially downrange, most of your burn patients, they're going to have some kind of trauma mixed in with all this. And if you focus on the burn, because it's super easy to do it, you're gonna miss an injury that could easily become a life threat later on. So stick with the March algorithm. You will pick up literally any of the things that will kill them or that would kill them are going to kill them faster than the burn will. That can wait.
Exactly.
Perfect. So another thing, that, especially with burns, inhalation burns, airway burns, those are another life threat. How do I decipher, especially as a child, they're breathing really rapidly, it doesn't feel like the normal breathing of a patient. How do I assess, is this an emergent airway, or is this something that I might need to think about, in an hour or two?
No, that's a great question. And it's honestly a point of contention, really in the literature and across intensivists and EM docs. So children's airways, because they're smaller, any bit of edema is going to cause them to lose that airway earlier. So while I can wait on an adult for true signs of respiratory failure, if I wait on that child, I might lose that airway. And if you're under 12, really under 8, you can't opt for a surgical airway just because the cartilage is not firm enough to tolerate it, then you risk significant damage to the airway. So I think it should always be a discussion. So same as an adult, GCS less than 8. So if you're unconscious, if you have large surface area burns, 40, 50%, I'd consider it. If you have any sort of stridor or they're really working to breathe, so you see the retractions pulling in, their belly moving, deep facial burns. So not just singeing of the face, but true deep burns, significant soot in the mouth. I'd think about intubating them. Hemodynamic instability, that's going to need a lot of resuscitations. A scarier indication, just because intubating somebody who's unstable, you do risk a cardiac arrest. But if you prepare for it, it is an indication for intubation. So it's really the same reasons as you'd intubate an adult with a burn. The tube size is different though. So you can use your length-based tape. Mila Medical actually just made a trauma tape that has all the burn calculations on it in addition to all the equipment and standard resuscitation. So that's a great option. The age-old rule, age divided by 4 plus 3.5 for a cuff tube. So for a 4-year-old, divide that by 4 is 1, plus 3.5 is going to give you a 4.5 ET tube. Or if you have no resources whatsoever, the child's pinky diameter is a last resort. But with burns and edema, you want to have at least 2 smaller ET tubes, half a diameter and a full diameter lower, expecting that edema and a difficult intubation.
Okay. So in my world, we don't really intubate. We don't have the narcotics for it. We don't have the equipment for it. And we tend to go straight for a surgical airway. That's kind of our bread and butter. Like you mentioned, pediatrics, especially real small ones, it's not a great option. Okay, so just positioning, if I can get their head and neck above their heart, in that I've watched it, like at least impede the swelling until, I guess, would you advise changing their position so I can try to get them to somebody who can intubate, doing something like that? Or is this not going to matter and just go for it because that's all you got?
That's a great question. And there honestly is not a great answer.
Yeah, that's perfect.
Yeah, you can, the position of comfort, whatever they're most comfortable in, but as that swelling progresses, you really don't have an option.
Yeah. So just definitely, you're going to have to move fast, right?
Mm-hmm.
So usually after that has been sorted out, your airway decision has been made. If they have no other life threats, now we can start thinking about burn resuscitation. So we get some kind of access point, either IV or IO. Mm-hmm. And now we would use a rule of 10s, but those are all adult. That formula was built for adults. So it's 30 up to, I think, 80 kilograms is the base, right? So pediatrics, generally, we're talking everything under that. And it's not difficult to over-resuscitate a burned patient. So I guess how do I first get some base numbers?
Yeah, so there's two schools of thought. Sorry about that. So during the initial resuscitation, when you don't have time to fully pull out your chart and get your burn numbers, you can do a standard for kids under 6, 125 mLs per hour. For kids 6 to 14, 250 mLs an hour. For kids over 14, treat them like an adult, 500 mLs an hour. Once you then are able to take out the pediatric Lund-Browder chart, which I strongly recommend doing, just because if you were to guess on a burn, you're talking significant fluid shifts, and I can easily over-resuscitate you with fluid. So take the extra minute or two, bring the chart over to the patient, record their percentage burns, and it does change. So for infants, it's 1 to 4 is their own age group. I believe 4 to 7, 7 to mid-age, and then adolescents. So the head is going to be up to 18% in a child under 1, and that's going to decrease with age, and your legs are going to increase by age. So because it is complicated, I bring the chart to the bedside and go through it there. If I don't have access to the chart, just like adults, a child's palm is going to be 1%. So I can roughly see how many palms the burn is. And I have actually moved the child's palm to get a rough idea on smaller burns. Once I have an idea of my TBSA, and just like adults, it's only 2nd and 3rd degree burns. So the superficial 1st degree don't count. Then you're talking your consensus formula. So this is where the math gets challenging. So 3 mLs times the weight in kilos times the TBSA is going to give the total volume resuscitation that they need. That number is then divided by 2. The first half is given quickly over 8 hours, and the remainder is given a little bit slower over 16 hours. So it does need a lot of math, but that is the standard consensus formula.
Okay, perfect. So that the first set of numbers, for pediatrics, 125 mLs per hour, and the 250 and the 500, that comes from the American Burn Association.
Yeah.
Yep. So we can start off with the amount of fluid. So one, like I tell my students, when you first encounter a burned patient, especially pre-hospital and even later in their hospital stay, until they get that first bath, they're going to be covered in soot and dirt and whatever is melted to their bodies. Getting a good TBSA, like a real accurate one, is not going to be easy. That's going to be a real trick, and even the most experienced of attendings are going to have a real hard time in that situation. So we have to start, right? Because their body is not, the pathology is not waiting for anybody. Get that started. Get time to get a fluid calculation, something ballpark, because it's still going to be ballpark because your TBSA is, assume it to be also ballpark. It's going to be wrong for the specific number, but you'll at least be in the same region as it should be. And then you start your resuscitation. Every resuscitation needs to be guided by something. And so for adults, we use urine output. Is that the same for pediatrics?
It is, but I did forget one critical detail. So in children under 30 kilos, they need maintenance fluids as well. So they need a dextrose fluid. Now, that's going to be the 4-2-1 rule. So children 0 to 10 kilos, it's going to be 4 mLs per kilo. As you get to 10 to 20 kilos, it's 2 per kilo for every kilo over 10 kilos plus 40. And then for larger children, it's every kilo above 20 kilos is 1 ml plus 60. So you have maintenance fluids on top of the Parkland, or the now called consensus.
And that's just dextrose.
Maintenance fluids never change.
Okay. But that's just, what kind of dextrose?
Great question. So it depends what you have. And if you don't have it, how can you make it? So I have yet to find many places downrange that are going to have dextrose fluids. But if I have an amp of D50, I can take an LR bag, take 100 mLs out of the LR bag and add 100 mLs of D50. Now I have D5LR. So that's going to be great. If I don't, and I just have a dextrose bag, a D10W bag, and normal saline, you can Y them together. So if the rate's 100, I want 50 of NS, 50 of D10W. That's going to make, when I Y it in, D5 half NS, which is another appropriate maintenance fluid. So it's kind of whatever dextrose you have, D5, D10, and making it to the concentration for the child.
Since we're giving like sugar, just because their metabolism was already crazy to begin with, now you throw a burn on top of it, it's gone berserk now. What goals are you shooting for glucose? Anywhere
100 to 180.
Okay, so essentially normal-ish.
Yeah. And it's really because the glycogen storage just isn't there. So as they get stressed, they just don't have the reserves that adults do.
So on top of your resuscitation, we have this maintenance drip of dextrose. Onto our actual resuscitation, what kind of goals are we shooting for urine output?
So for children under 30 kilos, you want 1 ml per kilo per hour. For children that are over 30 kilos, half ml per kilo per hour, really up to that kind of 30 to 50 that you would for an adult. Unless you have an electric burn or myoglobinuria, then you're talking 1 to 2 mLs per kilo up to 75 to 100 per hour.
So essentially, once you get rhabdo, it sounds like the adult and the pediatric urine outputs are getting like very close to each other, right?
Yep, the goals just flush it out.
Why is a pediatric your normal urinary output almost double that of an adult?
That is a great question that I actually don't know the answer. 2. We've always just used 1 per kilo in the younger children and then half per kilo in the older children. But physiologically, I actually don't know.
I don't know either, but since I read a book, I'll venture a guess, and you can tell me if it's close. So the pediatric kidneys may be fully formed, but they're not fully functional because they haven't created that the concentration gradient. Sound smart enough?
Mm-hmm. Yep, that could be, or when you look at if you were to take a 70-kilo man, 1 per kilo would be 70, half per kilo would be somewhere, 35? So as long as you took it by kilo, it's similar. But yeah, I've actually never thought about that. That's a great question.
But anyway, so up to from 0 to 30 kilograms, shoot for that 1 cc per kilogram per hour. And any other, I guess, endpoints for your resuscitation? I know urinary output is like the most reliable, but what other things do we need to look for?
Heart rate can be somewhat unreliable because you do have a surge response. Blood pressure can be difficult as they get more edema. You might have trouble getting a reliable blood pressure. So just like adults, it's really urine output. Mental status also is a big one.
One thing I've noticed just on the burn ward there, especially if people are looking at heart rates, they're looking at blood pressures, they're not really paying attention to urinary outputs that much. It's really easy to say that patient is in shock because their heart rate is elevated, their blood pressures they seem to be universally soft. So people, I've heard many times, the patient looks dry, go ahead and give them, another liter. And people say that pretty flippantly. I guess, is that okay?
From what I've seen, the only time I really bolus or give additional fluid is if they're hypotensive. And I don't need to give the full amount. I just give enough to correct the hypotension. Because we found that the more fluid we give, the more we get off our calculations, the risk of fluid creep, abdominal compartment syndrome, and the increased mortality from excessive fluid.
And those pediatrics, their lungs are real tiny. Their bodies, they're very sensitive to fluid overload. And if you're not dogged about paying attention to the urinary output and maintaining that, you're going to make things way worse.
Mm-hmm. And we say it all the time in the ICU, right? You get your 20 per kilo bolus in pre-hospital. The ER gives another 20, 40. Maybe they're admitted to the floor. They get another 20 to 40. And now that 60 max we're supposed to have is easily 100 to 120. And then they come to ICU with pulmonary edema and fluid overload.
And now you have to not simultaneously give them fluid while simultaneously trying to pull fluid out.
Right.
Outside of resuscitation, now I would imagine the next big threat is wound management and hypothermia management, as well as just pain and sedation, depending, right? So hypothermia management for a pediatric, I guess, what goals are we actually shooting for? How hard is it? Because their little domes are so big. You really got to pay attention to the heat coming out of their head.
Before we jump onto that, there's just a couple other resuscitation. Adults have now switched to plasma resuscitation for burns, which has made its way into pediatric protocols. The Vanderbilt protocol specifically says give, for any burn 15 to 50%, you can actually give 10 per kilo of FFP, up to 1 unit. For burns greater than 50%, you actually give 20 per kilo, or up to 2 units. And then you can also do a plasma drip if you have it available. And out of your consensus formula, that will be 0.5 mLs per kilo times TBSA. And then that total volume is divided by 8, and that's your rate. So just subtract crystalloid, just because they have shown that plasma resuscitation is better than pure crystalloid alone in burn for both adult and pediatrics. So if it's available, that is another option and does follow the adult guidelines well.
And I think it makes sense just because, hemorrhagic shock, we give blood. either component therapy or you give it whole blood, but blood is leaking out. We put more blood in. Things generally turn out better than if we give water. Burn resuscitation, you have plasma leaking out. Now we're putting plasma back in, and also that just works out better than just giving more water. Now with this consensus formula, I've also seen that either consensus, Parkland's, Brooks, modified Parkland's, modified Brooks. People, like we've talked about just between you and I about algorithms, people get stuck on an algorithm and the scientific method it came to get to that. Once you get an actual number, will you now turn to urinary output, or do you stick with the number it says to give?
Urinary output, just like the adults. Instead of changing by 20% of the fluid, we do go smaller, 10%. Just they're smaller and a little more sensitive to those fluid changes. So yeah, if your urine output is, if you're less than 30 kilograms, if it's more than 1 per kilo, drop it by 10% and observe for an hour or two. If your urine output is less than the 1 per kilo, just increase it by 10% and continue to follow that. So just like adults, you're going to titrate by urine output. It is unlikely you will have a pediatric Foley downrange.
Very unlikely.
So you do need to get creative with how to check urine output. If you can capture it and measure it, that's great. Diaper weights. We've actually found that 1 gram of diaper weight is roughly 1 ml of urine. So if you have a scale, you can subtract the dry diaper weight, and then whatever that grams is going to give you your mLs of urine.
Have you tried ultrasounding the bladder?
I have not personally, but it is something we routinely do. It's a bedside nursing skill. I have found that it is quite inaccurate and requires very specific measurements, and even measuring 2 to 3 times by the same person over 10 minutes gives you 3 drastically different measurements. So it is helpful, but definitely not the end all be all.
Yeah, so don't guide your resuscitation by that.
Right.
I don't know, when it comes to resuscitation, any other things?
No, like we talked about, just boluses for hypotension really was it. Otherwise, most of it is the same as adults.
Perfect. Hypothermia management, I guess, how big of a problem is that with pediatrics?
A lot bigger than adults. So children have roughly 3 times the body surface area to mass as an adult. So if I were to leave an infant exposed to the elements, they're going to lose their temperature a lot faster. So the principles of hypothermia management are the same. You just have to have a quicker pace with pediatrics. So wet clothes, cut them off, put them in dry clothes. If you're unable to debride the wounds, wrap them in dry dressings and then put a dry blanket on top of them and then your HPMK like you normally would. If you have the ability to warm fluids, definitely warm fluids. Children, because their head is so large, they lose a lot of heat from their head. So wrap the head as well, whether that's in a cap or a blanket wrapped around the head. Just the same strategies as an adult, just quicker in a pediatric patient.
You know, kind of talked about wound management. We're not going to be doing like the bath like you would get at a burn center. Like we're not going to be doing that. I really don't think, other than maybe some cleaning, basic cleaning, we're probably not going to go far beyond that. But any other, because with burn care, like I wouldn't say it's guaranteed it's going to get infected, but man, it is likely to get infected. Why don't I just give antibiotics up front?
Great question. Giving antibiotics up front is going to significantly increase your antibiotic resistance. And we've already shown through data in Ukraine that giving broad spectrum antibiotics significantly worsens the microbes that you have. They're more resistant. They're difficult to treat. When just treating them simply with penicillin, if they were to be infected, would actually mitigate a lot of that risk. But just like adults, if you don't see an obvious cellulitis or true systemic toxicity, we don't routinely give antibiotics in children. Clean it if you can, sterile water. If you don't have a tap water, whatever you have, if you can't, just dry dressings to wrap it up. So the exact same thing you do in adult PCC is going to be what you're going to do for pediatrics.
Probably one of the things that people are going to definitely want to jump into quickly is pain control.
Mm-hmm.
Pain control and sedation, at least potentially sedation. With pediatrics, I'm not super comfortable giving narcotics, just period. Mm-hmm. Now I throw a small child into the mix and my mind goes wild. So I guess what advice can you give me when it comes to giving narcotics? Which narcotics would be best for a pediatric? Do I have the same goals as I would with an adult as a child?
Yeah, great question. So my kind of rule of thought is start smaller. I can always give more. I can't take it away. So I'll always dose on the smaller side, especially if I'm uncomfortable and I don't know how the child's going to react. So if it's an alert and oriented child with a small burn, Motrin Tylenol with oxycodone is needed. So your oxycodone dose is going to be roughly 0.15 mg per kg. Give it 30 minutes, whatever you need to do with the burn, you can do. If oxycodone's not enough, morphine, 0.1 mg per kg. And they tolerate that very well. I've actually been surprised how much opioid a child can take before it truly sedates them. Now, if you do mix some sort of benzo or anxiolysis with the opioid, you are going to have more respiratory depression. So that is something you need to know. If you're going to mix the two, watch for that. Especially a child who is a little on more unstable side, I would avoid all Versed, and it'd probably go right to ketamine, which is going to be pain control for somebody with a degree of hemodynamic instability, and also for procedural sedation. So the dosing, again, very similar to adults. So TBSA has 0.2 to 0.3 mg per kg of ketamine for pain, sedation anywhere from 0.5 to 1. You should be fine, honestly, with 0.5 and have a couple doses drawn up. If they don't respond to that, you can always give the second one. But no, the meds are the same. The dose is just a little bit smaller.
Okay. The meds are the same. The goals are the same. Just like you said, you're just starting smaller. Mm-hmm. Now, where I find people, especially when you're giving ketamine and you got to jump this, the partially disassociated zone to get them fully disassociated. I guess, how do you recognize it when all they're doing is screaming?
They will stop screaming and you'll start to see nystagmus. So just like an adult, I'll watch for the eyes. Yeah.
So essentially you just keep pushing until you get nystagmus, and then you've arrived.
Yeah. So you'll see it. They'll be nice and calm. They might twitch a little bit, move a little bit, but once you start to see the nystagmus, you're in a good spot.
When it comes to the opioids, any reason you picked morphine versus fentanyl?
I personally prefer morphine just because it's got less airway depression than fentanyl does. Otherwise, whatever you have, both of them are great options. I
mean, also, I think morphine's a great choice just because of the duration of action. Like, exactly. It's going to last a lot longer than your fentanyls. You're going to be bumping fairly frequently. Have you used hydromorphone?
I have. I do like it, but the doses are really small. So if you don't have a 1 cc syringe, it can be really difficult. So the dose for hydromorphone is 0.015 milligrams per kilogram. So you're talking just a fraction of an ml for some of these small kids. And because it's really easy to miscalculate, I try to stay away from it. But it's an appropriate drug as long as you have the dose and you double verify like you would any opioid to a child.
When it comes to burns and pediatrics, is there any, where do we normally screw up when it comes to pediatric burns?
Fluid. We just give too much fluid. Yeah.
If that were to happen, or I receive a patient that's gotten way too much fluids, what can I do about it?
Titrate based on your urine output and get back to kind of your appropriate fluid goals. I mean, if you're fluid overloaded and you're having signs of respiratory failure, obviously obtain the Airway and your basic ABCs that you normally would. Otherwise, continue to titrate the fluid down to urine output and just continue.
And just let their body flush it out. Yep. And okay, perfect. Well, awesome. Well, I really appreciate you jumping on.
No, thank you. This was great.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.